Public Health Promotion, a population health research center, was established at Syracuse University in the Maxwell School through a generous philanthropic gift from Sid and Helene Lerner in 2011. Our faculty, staff, and students working in the Lerner Center focus on applied research and evaluation and service while advocating for evidence-based policies and practices. From their award-winning Healthy Monday campaigns to research on substance abuse, mental health, assisted living, veterans, and much, much more, the Lerner Center generates a remarkable breadth and depth of information and research on important health topics. You can see much of their work on their website, which is can be found, we'll post the link here shortly, but including a substantial policy brief series on their website, lernercenter.syr.edu. Dr. Shannon Monnat, Associate Professor of Sociology, Lerner Endowed Chair in Public Health Promotion, and Director of the Lerner Center at the Maxwell School, is a scholar of social inequality and social demography. She earned her PhD in sociology from SUNY Albany and has taught on the faculty at the University of Nevada, Las Vegas, and at Penn State before joining Maxwell in 2017. Shannon's research examines the correlations and consequences of social disadvantage, particularly at the intersection of place, public policy, and health. A common theme binding much of her work is a concern for rural people and places. Her research focuses on spatial differences in opioid misuse and mortality and other diseases and deaths of despair. She also examines associations between various social and public health policies and health behaviors and healthcare access. Shannon is not only a great researcher, she is a remarkable teacher in both undergraduate and graduate classes at Maxwell. Media and policy experts from across the country use Shannon as a go-to source. She frequently consults with national journalists, and in November was invited to participate in the White House's roundtable focused on reducing opioid overdoses. Shannon is joined today by Emmy Helander, a Lerner Graduate Fellow. Emmy earned her master's and PhD in industrial engineering and operations from Syracuse University and SUNY Buffalo. She was a senior research and software architect at IBM's Watson's Research Center before returning to graduate studies at Syracuse University to pursue a PhD in social sciences at the Maxwell School. She is interested in research that explores topics in public health and its intersection with emergency medical services, social inequality in healthcare, education, and unemployment, and how it affects the elderly, as well as social science research methodology. We are delighted to have Shannon and Emmy with us this afternoon. One last note on our ground rules before we start. When we get to the Q&A section following Shannon and Emmy's talk, please understand that they are experts in health, but they are not medical doctors. They are providing a high-level, big-picture perspective on the COVID-19 crisis for us. So we ask that you not ask questions about individual treatment recommendations. They cannot and will not provide you with a second opinion. They will not tell you if you should or should not be tested, or what you should do if. We ask that you focus your questions on the epidemiology, the demography of the disease, the vulnerabilities, and the associated policies. Again, that's later in the program, and we will ask that you raise your hand, leave your hand raised, or enter your questions in the chat box at that time. So now it's my pleasure to turn it over to Shannon and Emmy for their talk. Thank you.
Great, thank you so much, Scott, and the rest of the Maxwell team for organizing this event. We're going to be really pleased to talk to you today about COVID-19 within the context, the broader context of population health in the U.S. I'm a sociologist and a demographer who's interested in geographic disparities in health outcomes and what leads to those disparities. And we really think that responding to a pandemic is as much about social science as it is about virology and immunology, because human behavior and attitudes and political action have substantial influence on spread and ultimately on the outcomes of this pandemic. So here is what we plan to cover. We're going to go over the epidemiology of the disease. We'll talk about various place-level vulnerabilities, including vulnerabilities to high rates of spread, high rates of fatality, and of course the economic impacts. We're going to talk about some disparities that are being revealed and exacerbated by this epidemic. We'll talk about some of the cascading impacts beyond the infection rate and the fatality rate from COVID-19. And then we'll wrap up by discussing some light at the end of the tunnel and what we need to do to restart society. So before showing you some current trends and discussing the implications for certain vulnerable groups, we think it's important for you to have just a basic background on how scientists study and understand the spread of COVID-19. And so for that, I'm going to turn it over to Emmy and then pick up after she discusses the model of the spread. So Emmy.
Thank you. This is a very brief background on models used for COVID-19. The compartment models are fundamental. This graphic shows the classic SIR model. It's susceptible, infected, and recovered. These models help to estimate the basic reproduction number. It's also called R0, or if you see it, it's R0 on the screen. Roughly, this is the average number of new infections caused by one infected person. For COVID-19, R0 being used in the models is roughly 3.0. For comparison, measles just north of 10, flus, seasonal flus, the common cold are generally below 3. The estimation of prevalence is also important. This is the ratio of the population infected. It tells us about the epidemic process. Together, the testing for prevalence is quite different than the testing that's done for diagnosis. We should note that together the R0 and prevalence are important to project the scenarios and plan resources such as hospital beds, staffing, even things like supplies and ventilators. Finally, these models consistently show that aggressive social distancing and shielding are currently the best mitigation strategies.
Thanks, Emmy. How bad is COVID-19? Well, as of today, there are over 1.36 million cases and over 76,000 deaths worldwide. 75% of countries have reported cases thus far. The good news is that nearly 300,000 people who have been infected have recovered from the virus. This started in countries with a lot of travel, but it's basically everywhere now. A lot of countries don't have a very rigorous testing program yet, so we don't really know the magnitude of this spread like we wish we would. For example, we're not sure how many cases there are in several African countries. An important caveat to what we're about to show you is that the cases that we're going to show you throughout this presentation are an undercount. Cases are undercounted worldwide, they're undercounted in the US, and this is because we're just not doing a good job at testing. We're not doing prevalence testing, for one thing, which is something that Emmy mentioned. We're not even testing lots of people who have symptoms due to shortages in testing kits. So the testing counts are an undercount here. Deaths are also an undercount. There were and will continue to be COVID-19 deaths that were mistaken as influenza or some other respiratory disease and coded as that on the death certificate. Those deaths aren't going to show up in the dashboards that you see online or in the numbers that are reported by the press. It's really going to take some time to sort those out, and we'll always have an undercount of those deaths that are attributed to COVID-19. So why is COVID-19 so bad? Why are we so worried about this? There are several factors that distinguish COVID-19 from other infectious diseases like the flu. The first is either known or unknown immunity. There doesn't seem to appear to be human immunity, though we will be learning more about that as science progresses. The second is that COVID-19 is highly contagious. It is very efficient at spreading from one person to another, and it is spreading rapidly. Two key problems with that is the long incubation period, so up to 14 days is the incubation period, and that we have transmission from people who are asymptomatic. So these are people who don't know they're sick and don't feel sick, but nevertheless have the virus and transmit it to others. So you can't stop this just by avoiding people who are sick or who look sick, for example, who are coughing or who have the fever. Finally, this has a relatively high mortality rate. Most people survive, but compared to other diseases, the rate is fairly high, certainly higher than the flu. So what does this look like in the US? Well, as of today, the US has over 363,000 confirmed cases and nearly 11,000 deaths. New York State is the current epicenter of the outbreak, particularly within New York City, with the most confirmed cases and deaths by far. Nearly a third of all of the US's confirmed cases and 44% of the deaths in the US have been in New York State. This isn't a surprise given that it's the most populated state in the US, and the city in particular has a very high population density. But New York also has a lot of confirmed cases because it's looking for them. New York has made a dedicated push to ramp up testing at hospitals, labs, drive-through centers, and New York was the first state to authorize public and private labs to begin testing for COVID-19, and they did that back in mid-March. So about a quarter of all testing nationwide has been in New York State. So yes, a lot of cases in New York, but the epicenter is moving, and in the coming weeks, many cities will have a New York story. Already seeing the writing on the walls in Michigan and in Louisiana with surging cases in Detroit and New Orleans. We emphasize the importance of testing in the beginning. This first map that I'm showing you shows testing rates by state. Testing rates are low nationwide, but some states are doing a better job than others. The highest rates of testing as of today are in New York State, Louisiana, Washington, Massachusetts, and the District of Columbia. We're seeing low rates of testing in several Southern and Middle America states, Virginia, Texas, Georgia, Alabama, Kansas. They all have comparatively low rates of testing. This just overlays the percentage of tests that have come back as positive. So larger circles indicate that a greater share of all of the tests in these states have come back as positive. The highest percent positives so far are in New Jersey, New York, Michigan, Connecticut, and Georgia. And we need to be especially concerned with states that have a high percent positive, but also have a low testing rate. So states like Georgia, Indiana, Alabama, Virginia, Oklahoma, they have a low testing rate, but a high percent positive. So that's an indication that they're not doing nearly enough tests and that there's a lot of silent spread occurring in those places. This map shows the infection rate. So this is the number of confirmed positive cases per 100,000 population. As noted earlier, we see high infection rates, the highest rates in New York and New Jersey, but Louisiana, Massachusetts, Michigan, and Connecticut are all starting to surge. And now this overlays the case fatality rate. So this is the percentage of all infections that result in a death. And so larger circles mean that a larger share of positive cases in these states resulted in a death. And so case fatality rates right now are highest in Kentucky, Washington State, Vermont, Michigan, Georgia, and Oklahoma. And we're really concerned about these states with high case fatality rates. It could be a number of things that explain why their case fatality rates are higher than in other states, which we'll get to in just a minute. So when thinking about geographic differences, there are three types of vulnerability that we think we should consider. And the factors that predict vulnerability are different across these three different types. So first, there's vulnerability to high spread. And the factors that make a place more vulnerable to high infection rates, to high spread, are things like having a higher population density, having high commuting rates, having a high percentage of residents who are considered essential workers because these people continue to interact with others and with the public on a daily basis, having places or a high rate of communal living, so a high share of people who are living together. Insufficient testing, of course, makes a place vulnerable to high rates of spread. And then places that have been slow to implement social distancing protocols. So some states have made it more difficult for cities and local municipalities within those states to enact physical distancing through something called preemption. So for example, many Georgia beach communities implemented local ordinances that forbid public access to beaches, but then the governor opened up the beaches last Thursday. Some Mississippi mayors put restrictions on their town's residents and businesses, and they narrowly defined essential businesses to try to reduce people going out into the public. But the governor there preempted this, and the governor's order, while limiting gatherings in public to no more than 10 people, allows restaurants to stay open as long as there are fewer than 10 people inside at once. And many cities and counties have previously required restaurants to close their dining rooms completely, and the state's order disallows that. Arizona's governor issued an executive order that prohibits local governments from closing businesses that are included on the state's essential services list, which includes places like nail salons, pawn shops, and golf courses. So we're concerned about potential high rates of spread in those states. The second type of vulnerability is vulnerability to high case fatality rates. The factors that predict this type of vulnerability include having a higher percentage of residents who are older, so 65 years or older, a higher prevalence of chronic diseases because these increase risk of complication and death from COVID-19, places that have a poor healthcare infrastructure and low access to healthcare, including a high uninsurance rate, and places with a higher percentage of residents who are living alone because people might not be able to check on them. The third type of vulnerability is vulnerability to a bad economic impact, and we need to be concerned about this as well. So the types of places where the economies will be hit the hardest are those with a high share of labor force in retail, recreation, and tourism, a high share of workers who are self-employed, or a high share of residents who are working in small businesses. Places that have an undiversified labor market, reliance on a single industry or a firm where if that business shuts down, a large share of the community will lose their job. And then places where state and local governments have weak budgets, who just can't sustain the revenue hits that they're experiencing. We're at risk of a second wave recession where revenues will decline in local and state budgets. There'll be budget cuts in government and education sectors, and that could result in job loss. We saw that happening with the Great Recession as well. So we've really emphasized the importance of testing. And as with nearly all other health outcomes in the US, there were early racial and ethnic and socioeconomic disparities in COVID-19 testing, which could have important implications for long-term outcomes in these groups. About a week ago, I released a brief through the Lerner Center showing that state-level testing rates were lower in states with larger % Black populations and higher poverty rates. So for example, whereas the average COVID-19 testing rate in states with the lowest % Black populations, the bottom 25th percentile of % Black, whereas the average rate in those states was just over 400 per 100,000 population. The average rate among states with the highest % Black populations was only 206 per 100,000 population. And rates were also lowest in states with the highest poverty rates. Now, when I examined the data yesterday, the disparities weren't quite so pronounced, mostly because Louisiana and DC have really ramped up testing even more. They have large Black populations and have been among the states with higher recent testing. But these early testing disparities, as well as the states with poor and high % Black populations that still have low testing rates, have implications for disparities in COVID-19 outcomes down the road. Without proper early testing and without physical distancing protocols, these states risk a surge in silent spread, in severe cases, which could overwhelm their already resource-strapped healthcare system. What remains true from last week and continues into this week is that testing rates are lower in states with worse health. These testing data are current as of yesterday, and the figures show the number of COVID-19 tests that have been conducted per 100,000 population in the state on the y-axis, and then 4 state-level health outcomes on the x-axis. The 4 outcomes are life expectancy, % of adults reporting a fair or poor health, % of obese adults, and % diabetes. So if you take the top left quadrant, you can see that there's a positive relationship between state life expectancy and testing rates. So states with higher life expectancy have higher testing rates. Conversely, if you look at the other 3 figures, states with larger shares of residents who report fair or poor health, higher rates of obesity, and higher rates of diabetes all have lower testing rates. This is a major concern, given that the populations in these unhealthier states are the very populations that are at the greatest risk of serious complications and death from coronavirus. And we're not testing these populations at the same level. So what we're observing that this epidemic is revealing and also exacerbating large health disparities across US states. Further exacerbating all of this is that the same states with unhealthy populations also have worse healthcare access, meaning that testing rates are lower in states with lower healthcare access. These figures show 3 measures for healthcare access on the x-axis. The top right one shows preventable hospitalizations. These are hospitalizations for conditions that are usually treatable in outpatient settings. And so high rates here suggest the quality of care that is provided in the outpatient setting is really less than ideal. This measure might also represent a tendency for the populations in these states to overuse emergency rooms and urgent care as their main source of health care. And so preventable hospitalization stays are thought of as both a quality measure and an access measure. States with higher preventable hospitalization rates have lower rates of COVID-19 testing. The bottom left shows that states with more primary care physicians per capita have higher testing rates. And the bottom right shows that states with higher uninsured populations have lower testing rates. So what's concerning here is that states with worse healthcare access are going to be the least equipped to deal with the surge in cases when they occur. They're not going to have the facilities, equipment, medical personnel to handle the surge, and this could dramatically increase case fatality rates in these states. So what we're really seeing is a quadruple whammy. The poorest states are comprised of populations with the worst health and the worst healthcare access, and these are the same states where testing is paltry and where state governors have been slow or reluctant to enact strict social distancing protocols. So it's quite a mess. The Lerner Center also did a brief discussing why coronavirus could hit rural areas harder. Now, given their lower population density, the spread will be slower and later in rural areas, but fatality rates might end up being higher for a variety of reasons. First, rural populations are older, and this is bad news for rural America when it comes to COVID-19. Nearly 2/3 of small non-metropolitan counties are considered the oldest old counties, meaning at least 20% of the population is 65 years or older. In addition, rural areas have higher prevalence of several chronic health conditions that increase the risk of COVID-19. In addition to that, there's a much more limited healthcare infrastructure in rural areas. Since 2010, 126 rural hospitals across 31 states have closed. And even when hospitals are available in rural areas, most don't have the capacity to deal with the surge in coronavirus cases, and they have limited availability of medical personnel, ventilators, personal protective equipment, and other essential supplies. Especially concerning is that only 1% of the nation's ICU beds are located in rural areas. The more limited healthcare infrastructure also means that testing rates have been lower in rural areas. And then in addition to that, more rural states and rural parts of urban states have been slower to enact or to abide by social distancing protocols, which increases the risk of silent spread. To continue the bad news, there are secondary impacts from this pandemic. There are far more than what are listed here, but this is just to get you thinking about a few of them. So one group has to do with indirect deaths and health harms. So lack of access to healthcare treatment for other conditions or injuries could lead to increased mortality rates from other causes. Some procedures that were considered elective have been postponed so that hospitals can deal with the surge in corona cases. People are not going to the doctor for fear of contracting the virus in the medical setting. So certain types of mortality rates could increase. We could also see an increase in drug poisonings, alcohol misuse, and suicides. There's some evidence that alcohol misuse is already increasing. We know that gun purchases have increased, and access to guns is a major risk factor for suicide. We're also hearing reports in the media about increases in domestic violence. Many folks on this call have experienced increased stress. So we're seeing increases in parental and child stress due to disrupted routines. Sustained close proximity to your family at all times can be stressful to some people. Increased anxiety and anger at what's going on that we can't control. Parents who can't get work done because of childcare responsibilities. So those are some indirect potential harms. We also know that social isolation is bad for health. Humans need connections to other humans, and this is threatening that. The US was already doing pretty poorly in this department, but physical distancing protocols certainly have the potential to make it worse, especially for people who live alone or in unhealthy home environments. Another group of cascading impacts has to do with the economy. The economic impact here is already and will continue to be massive. This is far worse than the Great Recession because it was sudden and it has affected almost every sector. So we've already seen and will continue to see major job loss. Some small businesses will be lost. Of concern is that state and local governments are going to experience major hits to their budget through lost revenue. So again, this idea of a second order recession. And as with other economic downturns, low wage workers will be the most negatively affected and will have the slowest recovery. There are some silver linings, and we feel like it's important to point those out. Some deaths will be prevented. So for example, less motor vehicle travel will mean fewer traffic fatalities. Some people will have more time to spend with their immediate family. That, of course, depends on family structure and whether you're considered an essential worker. But some people are reporting more time with their family. I've seen reports of more sleep for both children and for parents. Again, this is for some. It depends on whether people are considered essential workers and whether they have time for more sleep. But not having to get your kids ready for school so early allows parents and children to sleep a little bit later. There's also been a reduction in pollution. So a recent study in China estimates that about 77,000 lives there will be saved by a reduction in air pollution during the shutdowns. So there are some silver linings to our reduced travel. So to summarize, cases and deaths will continue to increase. The increase will vary both of states, but also within states, and it will be staggered. So we need to be prepared to share personnel and equipment with other places in need around the country and within our own states as these cases surge in some places and reduce in others. Our public response and our policy response will really determine the pace of the spread. We still have a chance to reduce spread. And to do that, we need to take social distancing seriously. Testing should focus on estimating the infection prevalence versus diagnosis. So not just testing people who are sick. We already aren't doing a good job at that, but actually ramping up testing to focus on prevalence. Fatality rates are going to depend on the medical system's capacity, and this is why I'm so concerned about rural areas. Places that are unequipped to deal with the surge are really of concern here. We should also be concerned about states that have been slow or reluctant to react. Viruses don't stop at state borders. And there will be long-term impacts that we don't even know about yet. When can we restart society? Our view is that 4 conditions really need to be met before we can relax social distancing. First, we need to see a sustained 14-day decrease in cases. We need to see that the healthcare system can handle the existing caseload. We need to be able to test at least everyone who has symptoms, and this simply isn't happening. And we need to be able to trace confirmed cases and their close contacts. We are likely to see waves of outbreaks for months, especially if social distancing is relaxed too early. We need to maintain social distancing while the actual prevalence is unknown. As long as we don't know the prevalence, we can't relax social distancing, especially given the high rates of asymptomatic transmission, people who don't know they're sick, who can pass it on to others. Remember that 14-day incubation period is really quite serious. We know that treatments will continue to improve, but we shouldn't be lulled into a false sense of security because treatments will improve. And in particular, we need to continue shielding older adults and people with chronic health conditions since they're at highest risk of serious complications and death from COVID-19. We think that global travel will probably need to be restricted for longer because other countries also don't yet have a handle on this, and many have far less resources than the US does to be able to mitigate the spread. We can anticipate a vaccine in about 18 months. Vaccines take a while because they need to be tested and approved. So it'll be a while before we have a vaccine and can totally get back to this idea of, normal engagement out in the community. And so we think we should really be using this time to learn lessons about how to prepare for future pandemics. This one won't be the last. We should get a handle on what countries and states did things well, and then design protocols around what worked. And so with that, I will stop, and now I think we will take time for questions.
And Emmy, yes, we could take questions now. Please remember, we're not taking questions about individual treatment recommendations or what your doctor might be telling you. Please focus your questions about the disease, the vulnerabilities, and related policies. You can raise your hand, or you can type and leave your hand raised until we call on you, or you can type your question in the chat box. So we welcome questions. I see Patricia has raised her hand. Patricia, unmute your microphone and you can ask your question if your microphone's working. There you are.
Got it. Okay. Well, I live in New Mexico, and actually we've got an excellent governor, and our disease rates are pretty low comparatively. The problem is the other states, and so it's how can one limit, and how will they limit people from, let's say, Texas coming in and reigniting something that is more or less going to be gotten under control here fairly in a reasonable time. Because there's state laws, there's federal, interstate commerce, so forth and so on.
Yeah, so there are a couple of examples of this happening in some states already. I've heard that Florida, for example, is checking people at the border to the extent possible to see whether they're from Florida or not, and not allowing people who are not from Florida to cross the border. I really don't know how possible it is to do this on a larger scale. Emmy, do you have any thoughts about this?
It's a good question. It's a good comment. I think this is an extension of social distancing. You know, if you drive around, I don't, I've been home, but I've seen photographs of highways with signs that say stay home. And I think that right now that's an aggressive form of social distancing, keeping people in their states. And to the extent that people do that voluntarily is, the best thing. I like to say it is kind of interesting to see society buckle down in this way, because it shows caring not just for our own health and self-interest, but for the interest of other people in the community. It's come about pretty quickly, and so it's kind of interesting from a social dynamics perspective. Good comment, good question.
Shannon, I have a question. I'd like you to. You did touch on some of it in your presentation, but many people on television and other places have tried to compare COVID-19 to the flu and saying, this isn't much different from that. But can you speak to that, please?
Yeah, I actually prepared some extra slides in the case that this question came up, and that happens to be one of the slides that I prepared. So let's talk about this for a minute. COVID-19 is not the flu. It's much worse than the flu, and it's worse for a variety of reasons. For one, the R0 value that Emmy talked about in the beginning, the average number of people that are infected by one infected person, the R0 is larger with COVID-19. So one person infects more people. With the flu, it's about 1.3. And with COVID-19, it's anywhere from about 2 to 3 people on average who are infected. The second thing that makes this different than the flu is incubation time. The incubation time is just so long with this. So with the flu, the time from exposure to your first symptom is anywhere from 1 to 4 days, but with COVID-19, it's 1 to 14 days. And such a large share of people who are infected are asymptomatic, so they don't know that they have it. It's about 50% of people are asymptomatic, and so that long incubation period combined with the lack of symptoms really is a problem here. And the third is the infection rate is longer with COVID-19. So of all the people who get infected with the flu, only about 2% are hospitalized, whereas with COVID-19, it's about 19%. And then finally, the case fatality rate is higher with COVID-19. About 0.1% or even less of the population who gets the flu die from that, and that's compared with anywhere from 1 to about 3.4%, depending on age group with COVID-19. So great question.
Great, thank you. Tina had a question. I'm not sure. Tina Curry, are you still there? And do you want to ask
Yeah,
your question?
can you hear me?
Yes.
So I had a question about how how our government like compares to other countries in terms of doing a country like a U.S. wide stay at home, a function of our government structure being significantly different than other countries in order like not being able to do one, or is it more likely to
Great.
that
Thank
I mean, I'll let
one
you
has
jump in here too. I have one thought before I have you jump in, and that's a great question. So the U.S. has a very strong orientation towards states' rights. It has for a very long time, and the federal government is often reluctant to infringe upon states' rights. The U.S. in a lot of ways is a lot like Europe. Each state is almost like its own country, and that's what makes the U.S. different from a lot of other countries. And so that's part of why the reaction and response here has been at the state level instead of the federal government level. Emmy, do you have other thoughts?
Probably just a short one. I think it's a combination of cultural and political reaction. I also note, we're not an authoritarian government, so we rely on cooperation, and that's different from some other countries, and it's like some other countries. I also want to make a comment on the last, just reemphasizing the COVID-19. It's a novel virus, so there is no immunity yet, and that's one of the big differences from seasonal flu.
Thank you both. Appreciate it.
Thank you, Tina. Shannon, Kathy Daykoff wrote in, Maxwell Advisory Board member and a graduate of our and she's asking, with state and local governments so stressed, beyond widespread testing, what is the most impactful actions state and local governments could or should take now?
So with state and local governments so stressed, the actions that they're able to take are limited. I mean, they're really, the federal government really has to step up and try to stem some of the tide of the economic impact. And there are a variety of different ways that they can do that. By extending unemployment benefits, by providing Medicare to all people who don't have insurance to cover any of the costs that are associated with COVID-19, by expanding the match for people who are currently receiving Medicaid, by having an economic stimulus plan for after this is over and when the economy is able to open up. At the state and local levels, the single most important thing that they can do right now is to reduce the spread. That is how they're going to not be so strained in their healthcare system. And so taking physical distancing protocols seriously, enacting them, some states still haven't taken this seriously. The way that you reduce the impact on your healthcare system is to reduce the spread, and you do that by not lightening up on physical distancing protocols too early. Emmy?
Yeah, I would say added to that, continuing to encourage community action, things like social distancing, continuing to monitor and report and to make transparent the numbers as much as possible. That gives people information that helps them to judge and to contribute in their own action and in social distancing. I think local and state governments have a big responsibility in securing resources for medical response and things like that. Similarly, we live in New York. I think we have an excellent governor too. I do think we have a different situation in New York. We have some population centers that are very dense, and that's created a different situation for the transmission dynamics in New York. Yeah, that's about it. That's what I can think of. Good question.
Yeah, and to add to that, we've seen a lot of collaboration and sharing across states. So that's sort of a really positive thing that has come out of this, is that states have banded together work with each other to share resources, share data, share ideas, policy. And to the extent that they continue to do that, I think we'll be able to get through this a little quicker and a little bit easier. It's been really refreshing to see that state level cooperation happening.
Yeah, especially in California, what they're doing is fascinating. They're partnering up with smaller states to get resources instead of, just using their power as a really large and populated state. That is just completely fascinated me.
Yeah, and there are a handful of states who are working with universities to try to deploy more rapid testing, to try to come up with antibody testing. And so states that are working with their public and private partners are also able to deploy to maximize the resources that they have available to them.
Great. Are there more questions from our audience? We're happy to take them. Shannon or Emmy, is the curve, do you have some confidence in what you're seeing maybe in New York at least alone, or what do you think is happening out there right now?
It depends on where we're talking about. So the curve has started to flatten in some places. I don't think we can say the curve is flattening in New York yet, right? Cases continue to go up. We haven't seen a leveling off yet. Governor Cuomo continues to talk about this apex, and I think that's a really good way to describe what's going on. You need to see sort of you need to see systematic flattening, no growth over a certain period of time to say that the curve is flattening. This slide that I have up on the screen right now are data as of today. And this is showing deaths on a logged scale for different countries and for different states within the US from the day that they reached 8 deaths. And so you can see various levels of flattening here. For example, Washington has a much flatter curve. What we don't want to see are really steep curves. And so we see, New York has this really steep curve where we see sort of massive increase and it's continuing to increase, whereas Washington has a flatter curve. And what we really want to see is these curves continuing to flatten out.
Great. I do have a couple of questions coming in the chat box. Todd Yankee is asking, I live in Maine and learned today that the state of Maine tapped into LL Bean's supply chain to procure PPE from all over the world. Is this private-public partnership happening elsewhere?
I'm not aware of what's going on in the individual states. I think that's great. It's something that states have been asking the federal government to do. To the extent that the federal government is unable or unwilling, and states are able to take that on their own, I think that's phenomenal. It's good for the company to do something good for their community, and it's also good for the state to try to reduce the spread and also have a relationship in place for when the next crisis occurs. Because again, this won't be the last, and we need to set up protocols, get them in place now, so when the next crisis occurs, respond more quickly than what we've been able to do with this one.
Great. Pat Martino has written a question here I'll share, and it's some insight from Florida. Pat is in the Naples area, and she writes, just for some further detail on Florida, the state is stopping people at the borders, collecting information about where they will be staying, and indicating a 14-day quarantine is necessary, and giving information out as to personal responsibilities, social distancing, hand washing, etc. Then there is some monitoring of them at the locations they have registered, and Pat believes that some other states are considering our similar protocols. Part of the reason for all of this is the influx of young people during spring break, and then the number of people who've traveled from north to enjoy the beaches, etc., now mostly closed. Just an example of how each state has its own set of issues which complicate responses, uniform response across the country.
Mm-hmm. Yeah, thank you for providing those examples at the end about how, each state kind of being unto itself and complicating the kind of national response is an important one to keep in mind.
Sure. Here's a question from former Maxwell Advisory Board member, Maxwell alum Rajan Gill. Rajan is asking, what are the long-term ramifications? Is there any sense that the health access will change? It seems there's no coincidence the U.S. rate is so high given our fragmented health system. Just recently, the president shot down opening the ACA enrollment period. Also, do you think states that have refused to expand Medicaid might be moved to change their minds after this?
Oh boy, great question. There's a lot going on there. I've been thinking about this now since this all started, wondering like, will this be a wake-up call that there are serious limitations to the way that we deliver healthcare in this country? We have a market-based healthcare system, and as such, it is designed to maximize profits as opposed to, really supporting the collective well-being of the population. There has to be political will, and so if we start seeing more support at the public level through the ways that people vote, through cries to expand healthcare, then we could potentially see some changes. I mean, I'm hoping that people are seeing what's going on around them with their neighbors and understanding that there's been massive job loss here, and when your health insurance is attached to your job, you're at risk of very suddenly not having access to healthcare. But we have to remember that people lose their jobs every day, right? Businesses close every day when we're not in a crisis, and so people lose their jobs and lose their access to healthcare on a daily basis. And so once this COVID-19 crisis is over, if we just sort of go back to business as usual, we're going to sort of maintain this vulnerable population that we've always had in this country. I mean, add anything?
Oh boy, it's a great set of questions. This is a big shock to the big system, and I guess when I hear people talk about us going back to normal, there's something in my gut that says the new normal is going to be a different normal than what it was before, with a lot of changes. And my hope is that lots of the changes are for the better, especially for healthcare access, for Medicaid access, for lots of things, economically even too. There may be new economic circumstances that create new businesses, that create new kinds of things that sort of reset our society in ways that could actually be good. So, hope, and that's what I like to think about in this really, really big shock to the big system.
Great. Questions from our guests? Certainly, we're happy if you raise your hand and leave it raised. We'll call on you, or you can type it in the chat box. Emmy and Shannon, I wonder, often talk with our students and with others about quality resources for information. What are the best places for them to really get a sense of what's going on, and that's put in the proper context and behind it? Can you give us some of your thoughts on that?
Yeah, that's really important, especially in a time like now where there's a lot of different disinformation happening, a lot of conspiracies and rumors, which is concerning. We have enough to be worried about without having these conspiracy theories floating around. And so social media is generally not your best source of information for facts about what's actually going on. The Lerner Center has a website on COVID-19 resources, and we update this regularly, and we have a number of links on here that you can go to get up-to-date information. So we have the CDC's website. If you're interested in the numbers and the data, we've provided a link to Johns Hopkins mapping dashboard, which is updated in real time. We also have links to Harvard Medical School. We have links for health professionals and for decision makers. And then we have some tips on here about how to protect yourself and prevent spread. And then, we link some new research on here as it comes up. So we would encourage you to go to our website to check that out because we're very cautious about the sites that we link up there.
Fantastic, thank you. we probably have time for another question or so, but oh, Patricia has raised her hand. Patricia, if you want to unmute your microphone, we should be able to hear you.
Okay, one comment and one question. I spent a lot of my career working and studying and also working in and on Russia, and I would just point out that the statistics that are coming out of Russia, such as they are not very good. They're way underreporting. You probably know that, but just, you know, when you think about the propaganda value, that's one of the places it is. Don't believe them. Second, my question though is very different, and you've been talking about a little bit about your research on rural and underdeveloped areas in the States. What are you seeing in terms of the Indian reservations, of Native American reservations? I know what I see here, but that's a narrower perspective.
Yeah, that is a great question. And it's such an important population that is just overlooked in our conversations about population health to begin with, and has generally been overlooked in this conversation as well. You know, NPR has done a couple of good stories about it. What I'm hearing and seeing is that this group has a really high case fatality and infection rate. Part of the reason for the high infection rate is that, and the fatality rate, is that their healthcare system there is already under-resourced. The federal government and the reservations have not always had a very good relationship, and so resources aren't being deployed there as much as they should be. But also there's a high communal living in these communities. And so, you know, in American Indian areas, we think about homelessness a little bit differently than we generally do in the rest of the population. There are a large share of residents in these communities that don't have a permanent residence. And so they're living with a lot of family members, and they kind of bounce around from home to home. And so that really increases the risk of spread. And these populations already have really high poverty rates and a lot of chronic health conditions. And so there are just so many reasons why they're among the most vulnerable group for something like this. Great question. Thank you.
Okay, thank you.
Great. So thank you all for joining us. A really special thank you to Emmy and to Shannon for spending your time with us this afternoon. That was really helpful and just great. We will have it recorded. It will be on the Maxwell YouTube channel shortly, so we'll encourage you to share it with your friends and encourage people to check it out. I certainly want to thank both of you, Emmy and Shannon, but also Maxwell's outstanding technology team, Tom and Matt, and the Dean's Office, and Jessica Murray, our Director of Alumni Engagement, for organizing today's event. We'll continue these conversations and questions and answers with top Maxwell faculty